The conference is focusing on preventive cardiology. Like for many things in India, there are two Indias when it comes to coronary care. India which gets PCI and India which does not get PCI. So, what is the percentage distribution of people who are able to manage with PCI and people who are not able to reach to a PCI enabled center? And if the patient is not reaching at a PCI enabled center, what recommendation will you give to the physicians who are receiving those patients?
It's very apt that preventive care is very important to prevent the occurrence of this coronary artery disease epidemic and which culminates into ACS and acute MI what you're talking. If you see, acute MI is the worst possible thing which can happen in a cardiac disease to anybody, but at the same time it's also important and for us to understand that if proper preventive care is taken, 80% of occurrence of it can be prevented. Okay, we have documented proven data and recently published a study in JACC that 81% of the incidents can be prevented if the preventive recommendations can be fulfilled. But unfortunately, only 1% of the population which suffers takes care and attributes to all those preventive recommendations which are being done. So it's very important not to neglect this aspect of preventive cardiology. I congratulate Dr. Chopra and others for taking this initiative and conducting this conference in this holy place of Brahmakumaris. Acute MI and primary PCI, unfortunately in India, though cath lab numbers are increasing, they are quite unevenly distributed. Most of it happens in cities. Very few, I would say less than 5 to 10% of labs are catering to tier 2, tier 3 cities. But unfortunately India, on the other hand, is 80% of those villages, and then few very less percentage ranks into the tier 1 cities. But acute MI happens both in cities as well as in villages, both in rich as well as in poor. So what is most important is to reperfuse the artery in the acute stage. The first 1 hour is a golden stage and maximum up to 3 hours. And if you can reperfuse and make the artery open, then most of the myocardial damage can be avoided. This is a well proven fact. But as you said, primary PCI is proven beyond doubt, it is good. But the problem with it is access to it is not there in many centers. Coming to the last NIC data of ours, if you see less than 4% of the total population which suffers acute MI gets into primary PCI. That means huge 90+ percentage is not able to reach it. And the other thing is, if you see the total number of PCIs which are done in the country, if it is maybe 1.6 lakhs, out of which about 11% are done in acute MI stage. Though it is important number, but I would say compared to total number of people who suffer myocardial infarction, what is the primary PCI being offered is in a less number of patients. So then we are left with what? We are left with the established therapy of pharmacology, that is reperfusion with thrombolytic drugs. It's very heartening to note, I am very happy to say that we have very good advancements happened even in the pharmacotherapy. The age-old streptokinase, which we all know, many physician colleagues were worried to give that medicine because the moment you started it, there used to be hypotension, there used to be problems, and it was needing to be monitored for an hour or so. Then now if you have and patency rates, opening of the artery was also about 50%. Now we have better thrombolytic drugs which are more fibrin specific and which are less complication prone and more better opening rates. This is documented data. We have tenecteplase, we also have retiplase coming up, but the cost of it is slightly high. So I feel probably tenecteplase is somewhere in between the cost, and the opening rates is also about 80%. We in our group in Hyderabad and peripheries did lot of data where we connect patients who come with tenecteplase therapy, and then we are promoting this concept of giving tenecteplase in non-ICU setups where a doctor who is confident of diagnosing MI can give this therapy without wasting time and then shift the patients for places of PCI. Then the problem only thing is you have to identify the right patient. You can't give tenecteplase. There is a challenge sometimes for physicians or peripheral doctors or general practitioners to diagnose acute MI because it should not be given to a wrong patient. That's where the technology, that's where the internet, WhatsApp and these various things which are there will help us. We established a protocol where peripheral doctor takes an ECG, and whichever doctor is comfortable, think it is a good thing. Each physician should team up with one of the cardiologists, whomever is comfortable with, and then transmit the data to him, get it confirmed that it is acute MI, and then immediately then once it is done, giving the therapy is quite easy. Anybody who can give ranitidine injection, anybody can give IV injection, can give tenecteplase. It's like a one bolus injection. So I feel this newer thrombolytic therapy is very apt and good for our country. And then one more thing which is also important apart from the thrombolytic therapy is usage of newer antiplatelet drugs and usage of high dose statins. These are again proven beyond doubt that is beneficial. So apart from the ecosprin, which is given, aspirin, which is given 325 milligrams, if generally clopidogrel is very freely available, still people, lot of them use clopidogrel. So loading doses of 300 milligrams. Then, but if you have an access to more advanced antiplatelets like ticagrelor or for that matter prasugrel. Only challenge with prasugrel is some physicians do feel that prasugrel has more bleeding tendency, especially when you're combining with a thrombolytic therapy. So ticagrelor can fit somewhere in between, and then probably it has more better antiplatelets and less chances of bleeding. So if you are combining with a thrombolytic therapy, probably ticagrelor may be more suitable than prasugrel. But if patient is young diabetic, less chances of bleeding, good body weight, you can as well give prasugrel. That clinician needs to use his judgment. But if there is a confusion, better at least to give clopidogrel and aspirin and then followed by the thrombolytic therapy. One other important with this newer tenecteplase or fibrin specific things which are very having short half-life is it has to be immediately followed up, or for that matter can be just simultaneously given with antithrombin like heparin or low molecular weight heparin. So we recommend generally giving subcutaneous dose of low molecular weight heparin, and then patients will be shifted after that, depending upon the comfort level of the patient as well as the doctor and the availability of nearby center. Then you buy some time. There is no urgency to shift within 1 hour now. You gave thrombolytic therapy, and then patient could come in time depending upon the various arrangements which he needs to make, be in between 3 to 6 hours. And then we watch the patient once he comes to a referral center where PCI is available, and if patient is unstable, which happens in about 20% of patients, then we may rush to take it up for immediately. If patient is stable, probably you can do angiogram electively and then decide what needs to come, what needs to be done later after angiogram. In our data, one more interesting fact we found out is people who are given thrombolytic therapy, when they presented to PCI center, 50% of them did not need anything. 50% of them did not need any stent or any further procedure because the artery is already open. And another 15% of them had multi-vessel disease, which otherwise you would have ended up doing a culprit vessel PCI and then followed by a PCI again or a surgery depending upon the anatomy. So in about 65 to 70% of the patients, the outcome or the modality of therapy is changing by following this pharmacoinvasive strategy. Probably in our country where patients are more young, more spasm, more of thrombus, this may be more apt than doing direct primary PCI. But we need to have more randomized studies data on that where you compare pharmacoinvasive versus primary even in centers where primary PCI is available.
Any particular protocol this PCI, non-PCI enabled centers should follow when they have to transfer a patient to a PCI center?
Basically, when a patient is stabilized with thrombolytic therapy, that means, as I said, 80% of the times arteries are open. We have seen patients' pain decreasing, hemodynamics improving, heart rates improving better once the right drug is given. The beauty of it is, if it opens in 5-10 minutes like doing a PCI. Okay, the immediately patient's pain stabilizes, ECG ST elevation settles and hemodynamics improve. So in that case, there is no big deal no big urgency, but only problem is sometimes you get reocclusion. So it is important to give low molecular weight heparin injection at the same time, and then you get some time period of whatever time which is comfortable with the patient. By and large, if reocclusion is not there, patient can take time in getting stabilized. And I don't, we have initially used to use these 108 ambulance services to transfer these patients where you had sometimes availability of defib, sometimes defibrillators are not available. Idealistic scenario, probably yes, you should have an ambulance in which you have this ACLS protocols available, and if required, emergency medical technician while transferring this patient. If at all, in the sense that reperfusion arrhythmias or VTVFs, if at all, if it happens, sometimes they could be useful. But in our study where we had about 207 patients, I am very happy to note that but for those 4 patients which had some trouble and died in the primary clinics itself, apart from the rest of them 203 patients, none of them had any trouble while transfer. So what I am saying is, if patient improves immediately, there is less chances of having trouble. So now we are not insisting on transferring in an ambulance with all the facilities. If it is available, it is well and good. Otherwise, sometimes the patients do come in their own vehicles also. So, but idealistically, probably you can have some link up, some sort of ambulance in which it can be transferred. And what I want to guide and advise my physician colleagues who are comfortable now giving thrombolytic is, there is no need to rush to shift. Suppose there are arrhythmias happening, there is some hemodynamic instability, watch them, maintain for some time. Once the rhythms problems settle, once the blood pressures improve, then he is more comfortable to be shifted. In that low blood pressure stage or a beating abnormality stage, if you want to shift, there could be some troubles. So once the pain decreases, so little sort of reperfusion arrhythmias keep happening for some time. So those can be monitored, watched. And then once that sort of rhythm abnormalities settle, once the BP becomes more stable, then patients are in a better shape to be transferred to these centers. What I mean is, if patient has ongoing pain, if patient is in shock, if patient has some other mechanical complication or something which is continuously troubling the patient, then it is a different ball game. Then you should not take your sweet time. You have to be shifted, probably and preferably in a better ambulance where he has all these facilities. And then you have to also alert the tertiary center where the patient is being shifted, because maybe he will require immediately opening of the artery once he reaches. So door to balloon time should be made short, and then all those precautions should be done to open up the artery as soon as possible. But this necessity is generally there in about 10-20% of total acute MI patients. Rest 80%, once they are stabilized, maybe within 3 to 6 hours time they can get shifted. And then depending upon the comfort level of the cardiologist and the center which is available, what time is reaching, then we do continue giving heparin and the plan angiogram and revascularization if necessary in elective way.
What advice you will give to the people who have symptoms like heart attack? So if they feel like that, what they should do?
First of all, whenever there is any doubt of heart attack, please do not neglect. People think it as gas, and then get bloated up outside and go up to heaven. So please do not neglect it, be it any sort of discomfort, and don't neglect it. And doctors also should not ignore it. When there is doubt, you always treat towards more as CAD than as APD or gas. So any sort of discomfort which happens from the umbilicus to the jaw, and especially when it is increasing with exertion, and especially when there is a diffuse type of discomfort radiating to arms, it can't pinpoint to one particular place, associated with sweating, sometimes vomitings. These could be the clinical scenarios in which it could be MI, and then probably ECG will be more diagnostic. But sometimes in the early evolving stage, EC may not be abnormal. So clinical symptoms, what presentation which the patient has, is most important. So what I would like to mention, and again caution, is don't neglect any discomfort as gas or anything unless it is proven otherwise. Now we have enzymes also available, if possible even in peripheries it is being there. And then ECG also, serial ECG taking is important whenever you have a suspicion of ACS or acute MI evolving. So by and large, there is nothing wrong. If you err towards treating as MI, giving antiplatelets, giving statin is okay. If you have, maybe you can also give pantoprazole or some sort of drug along with it, but err towards treating as ACS rather than missing it out totally.
There are 3 or 4 antiplatelets, major antiplatelets, which are available options to the physicians. We have discussed briefly about the initial phase, but when it comes to a chronic phase, especially the dual antiplatelet, anything you would like to mention about that?
Yeah, this is another important query which many physicians have. Basically is how long we need to give this dual antiplatelet therapy. If a patient, any patient who has suffered acute coronary syndrome, it be acute MI in STEMI or unstable angina with ECG changes, at least you should give dual antiplatelet therapy for a year. Probably in our scenario, probably where I feel there's more of platelet stickiness, especially with diabetics and young people, it is better to give them little longer, because we have lot of data coming with clopidogrel that is quite safe and less chances of bleeding, because we do see a lot of younger population who suffers with it, unlike West. If the patient's age crossing 70 years, then there's more chance of bleeding and other problems. We do less commonly in our place, especially with clopidogrel. But if you are giving prasugrel, probably you need to watch and have a more cautious approach. But by and large, dual antiplatelet therapy is required for a year after ACS. Along with the antiplatelets, it's also important to give high dose statins. Many physicians we see writing 5 milligrams of rosuvastatin, 10 milligrams of atorvastatin, which is homeopathic doses, I would say. Now it is proven beyond doubt by many studies that high dose statin therapy is a must. So initially, for at least first 3 to 6 months, we tend to give 80 milligrams of atorvastatin and 40 milligrams of rosuvastatin, and then titrate according to lipid levels which this patient has. And if a patient post procedure or during angiogram and PCA had a drug-eluting stent, then it is all the more very useful to give platelet therapy longer, definitely for a year. But many cardiology colleagues do continue it for more longer, because we are a little more comfortable giving antiplatelet more longer. But there is more reassuring data that newer type of drug-eluting stents are more patient-friendly and less thrombus prone, even if you stop the second antiplatelet as early as 3 to 6 months. But I would say the recurrence of events always may be less, at least if you continue for a year.
Diabetes and young hypertension you specifically mentioned. Are there any other risk categories where you would like to give it longer than a year?
It depends upon the type, how the patient is behaving, what is the patient's anatomy also. Suppose patient has a recanalized vessel, there nothing is needed, then probably antiplatelets for a year or so, followed by just continuing aspirin and statin longer may be enough. But if a patient has diffuse atherosclerosis, if a patient has multivessel disease, if a patient has 2 or 3 stents placed, or if a patient has recurrent symptoms after the procedure, and the patient has, as we said, diabetes and multiple other comorbidities, then he has more reason to continue this longer. But even otherwise, I would prefer giving this dual antiplatelet little longer. We do see sometimes the problems of platelet resistance, especially with only aspirin. Now there is more thought process going on in diabetics. Aspirin alone may not be sufficient. So probably there would be more and more use of clopidogrel, other types of antiplatelets coming up in future.
Okay. Antiplatelet resistance is of course one of the reasons you mentioned. Are there, so on the other side of it, what are the things which point towards having a higher bleeding risk? And in any particular category you would like to avoid giving a dual antiplatelet therapy?
Yeah, the other thing is also important. In medical practice, do no harm to patient is also first important, rather than doing benefit by giving some special drug or doing some procedure. So you can't afford to produce bleeding in patients when you are treating the patients, because bleeding not only requires immediate blood transfusion then and there, but it indicates higher prognosis, higher bad prognosis, higher mortality on follow-up. We have now data, all these patients who bled not only have trouble acutely, but in the long term also there's more chances of they getting suffering with recurrent problems and higher mortality. So it is very important for us to assess the patient profile and then decide what sort of antiplatelets, how long you are giving. As we discussed before, the thinner body weight, elderly population, more than 70 years, and then patients who have a borderline kidney function, patients who are anemic, patients, we call it as poor protoplasm in clinical practice, that is very thin, frail females. These are some of the subsets of patients where we need to be a little more careful, especially if there is history of prior history of bleeding or APD in these patients. All these subsets of patients we need to be a little more careful. I would say that in such patients you come down on the dosing of antiplatelets more earlier. Maybe immediately after 6 weeks to 3 months you come down and giving a dose, and then probably you can giving less type of antiplatelet potency. One important other factor in these patients, as we should understand, is when you are using a ticagrelor, this aspirin should not cross 100 milligrams, because when aspirin was given at more dose, with ticagrelor there was more bleeding. So when you are using ticagrelor, you are supposed to use only 100 milligrams or maybe 75 milligrams of aspirin. So this is important. Like unlike with clopidogrel or with prasugrel, if you use 165 milligrams of aspirin, there could be more bleeding chances with ticagrelor. That's what the data show.
Thank you so much, sir. This was a really interesting discussion.
Okay.
We have covered two important topics. One was management of myocardial infarction at a non-PCI enabled center, and second was dual antiplatelet therapy. Thank you so much. Any final word you would like to say to the people?
As I said, and also very apt for this conference today, putting stents, giving thrombolytic therapy is all good, but finally it's always more important for all of us to understand prevention is always better than cure, be it primary prevention or secondary prevention. Primary prevention, it's always good if you can avoid getting the disease itself. But the thing is, the preventive measures is a challenge for everybody to do it. But you have to be committed and maintain your healthy lifestyle, avoid eating cheese, pizza, burgers or junk food, and then maintain healthy body weight. Do walking, yoga. Brahma Kumaris support a lot of yoga and meditation in prevention. But whatever sort of relaxation each person can follow is very important, because I feel healthy and happy person and being happy is also very important to prevent the occurrence of disease. If person is not happy, if he is stressed out too much, then probably that will do disease. So that's important, primary prevention. And secondary prevention also, after somebody suffers or some stent is put, it's very important for them to change their lifestyle and take medications as recommended, and then follow all the precautions of the doctor. And then probably the rehabilitation patterns, the yoga, lifestyle measures are also equally important. And one very good thing which is heartening for everybody to know, especially the cardiac patients and treating doctors, is the cardiovascular physicians have done wonders to these patients. In a large study recently, about 25,000 patients, when they were followed up for 12 years, which is published in JACC, they said the commonest cause of death which is happening in these patients is not cancer, is not cardiovascular mortality, but it is cancer. That is to say that we are able to take care of these patients, and secondary prevention is very effective, and these patients are living longer and they are dying of cancer or some other cause than the cardiovascular thing. So that's a very commendable job with all the cardiovascular physicians and pharma colleagues have done to these patients of cardiovascular disease, even if they suffer an event. But it's always, as we end, the prevention is better than cure. Thank you.
Thank you so much, sir.